Yes, sir.
Yes, sir.
So first of all, thanks to Ayurveda Mumbai branch for inviting me for this webinar in connection with World Diabetes Day that is commemorated tomorrow, and Rajendran sir for the kind words. And then I offer my humble pranams to our Guru, late Padma Bhushan, Dr. P.K. Warrior. So we'll go to the presentation. First, let's start with a story. Imagine children eating up ramen noodles with dry Kool-Aid powder sprinkled on top for breakfast every day. The children is taking raw ramen noodles for snacks, and for breakfast this Kool-Aid synthetic powder, flavored powder sprinkled on that, and adults eating cake, donuts or pancakes prepared with a cup of sugar and smothered in syrup, and families dining on white rice and canned meat, especially pork, for lunch and dinner every day. Just imagine an area or a country like that. It is there as Marshall Islands. You all might have heard about Marshall Islands. That is in the South Islands in the South Pacific Ocean, and it's a small island. Right in 2017 census or 18 census, the population was only about 53,000. And during the First World War, it was under Japan, and later in 1944, American took control over the Japanese, and they were ruling these islands, this Micronesian islands. And then later, all the Americans did their nuclear test on that island from 1946 to 58. The world's first hydrogen bomb named Mike was also tested there. And after that, in 1960s, United Nations took over the island, and they are given their government, etc. So why I'm telling about Marshall Islands is that due to these invasions, their lifestyle, their food habits, everything got changed, because now Marshallis rely on imported goods such as wheat flour, foods high in salt, sugar, and fats, and they commonly snack on uncooked ramen noodle, drink tea and coffee throughout the day and night. A typical serving of coffee, that too ready-made coffee, that is includes 1 to 2 tablespoons of instant coffee and 1 to 3 tablespoons of instant creamer and 4 to 6 tablespoons of sugar. 50 years ago, diabetes was virtually unheard of in the Marshall Islands, because in 1950s, only 3 cases of diabetes were reported in that island. And they have changed their diet. And during those times, the people were slim and active and lived off the land. The diet consisted of such edible plants as coconut. Coconut was there. Breadfruit is there. It's like a small, means jackfruit kind of fruit. And then taro, it's colocasia, and in Malayalam it's called as chamber, and pandanus. That was their staple diet during those times, and leafy green vegetables, and in addition to fishing was their main occupation, and other seafoods were also in their diet during those times. And right now, means few years back, Marshall Islands were in news because it had the highest prevalence of diabetes in the world. Almost 1/3, that is 31.4% of people aged between 18 and 99 years in that island were having diabetes, and 75% of people over the age of 50 years were diabetes. Means 3 in 4 people above 50 was diabetic there, and more than half of all the hospital admissions in the capital city of Majuro are due to diabetes. The most common procedure that was conducted, otherwise that is conducted in their hospital, is amputation, limb amputation, and 60% of deaths in adult under the age of 60 years are due to diabetes, and 75% of women and more than 50% of men were overweight or obese. A study was published. 2019. A study was conducted published in 2019, an intensive lifestyle intervention to treat type 2 diabetes in the Republic of Marshall Islands. Because this was conducted by American Diabetes Federation. So keeping the story of Marshall Islands in mind, we will today discuss the topic diabesity and age of growing waistlines. So a study was conducted in 1970 in a prison of US by a Dr. Sims, Ethan Allen Sims. He was a scientist in US at the Vermont University, and he conducted a study on prisoners in Vermont prison. He took some 80 to 20 men without family history of diabetes mellitus, and he gave them good calories of food. And that means they were overfed. Up to 10,000 kilocalorie per day they were given diet. And the total study duration was 10 months. And it was found that all these people, their body weight increased 15 to 25% in 3 to 4 months. And then 4 to 6 months. Sorry. After that, he withdrew the extra calories, and by 10th month, their calories was restricted, means up to 1,800 to the normal calories. And the weight gain was reversible in those prisoners. And the mean weight gain was 16.2 kg, of which 10.4 was fat tissue. And in all these prisoners, glucose intolerance and hyperinsulinemia were noted during those time. And he came to the conclusion, and he coined a word, diabesity. It was coined by Ethan Allen Sims in 1973. It describes the close relationship between type 2 diabetes mellitus and obesity. And we know in World Health Organization's publication in 2005, 90% of people with type 2 diabetes are overweight and obese. We know the definition of diabetes. Diabetes is a disease that occurs when your blood glucose, also called blood sugar, is too high. That's a simple definition, and it has different types. The type 1 diabetes is there, and it's a condition where your immune system destroys insulin-making cells in your pancreas. And type 2 diabetes is the matter of discussion today. And gestational diabetes, we know that happens during pregnancy. Your placenta is making extra hormones that builds up glucose in your blood. Usually, your pancreas, our pancreas, can send signals to handle that extra insulin. But if your body cannot make enough insulin, then the diabetes shows up. And that happens usually women having PCOD or having overweight. And then the other type of diabetes, the MODY, the mature onset diabetes of the young, is a name given to a collection of different types of inherited forms of diabetes that usually develop in an adolescent or early adulthood. MODY kind of diabetes is a monogenic diabetes that's usually caused by a single gene mutation. So we will discuss today the type 2 diabetes mellitus and obesity. It is characterized by chronic hyperglycemia usually associated with microvascular and macrovascular complications. We can see diabetes patients when they start showing hyperglycemia. Most of the patients, like WHO told, 90% of them will be obese, and later in the course of the 10 or 15 years, they would end up in insulin. At that time, they will be lean with flabby skin and all, and they would be having microvascular and macrovascular complications, and generally arise from a combination of insulin resistance and beta cell dysfunction. So these type 2 diabetes mellitus, the two main events are insulin resistance and beta cell dysfunction. We'll go to these components later. Then the diagnostic criteria for diabetes mellitus, we all know the symptoms of diabetes mellitus: the polyuria, polydipsia, polyphagia, all those things we know, and that all those things are created due to we have blood contain more glucose, but all our tissues are deprived of glucose. They are craving for glucose. That is why we have all these symptoms. Our nervous, the hunger center in our brain is activated, is stimulated, and that is why we have all these symptoms. And the kidney will be trying to as the glucose is more in our blood, the kidney will be trying more, and so more urine is pass out. And then symptoms of diabetes mellitus is there, and plus fasting plasma glucose more than 125 microgram per deciliter. Fasting is defined as no caloric intake for more than 8 hours. And 2 hours prandial glucose more than 200 microgram per deciliter urine. And HbA1c more than or equal to 6.5%, and random plasma glucose is more than or equal to 200 microgram per deciliter. This is according to the 2016 American Diabetic Association diabetes guidelines. And then testing for diabetes mellitus or pre-diabetes in asymptomatic adults usually is done if that person is overweight or obese, or if who have one or more diabetic risk factors, and test should begin at the age of 45 years. If normal, that test should be repeated every 3 years. Risk factors. The conditions associated with insulin resistance, severe obesity, acanthosis nigricans. Acanthosis nigricans, you all might be knowing that in obese individuals or in women having PCOD and all the skin folds, like neck is there, then armpits, and under the breast, everywhere, that black mark will be there. That tough black skin will be noticed. That is acanthosis nigricans. Acanthosis nigricans are 2 types. It's malignant is there, and benign is there. And here that is benign acanthosis nigricans, pseudo acanthosis nigricans, that is caused due to the hyperinsulinemia in blood, because in the first stages of diabetes, or when we are obese, we have high insulin in our blood, and that is the cause of acanthosis nigricans. And then PCOS is a risk factor. Then physical inactivity, first degree relative with diabetes mellitus. If we have a first degree relative having diabetes mellitus, then that is also considered as a risk factor. And women who delivered babies more than 4 kgs or were diagnosed with gestational diabetes mellitus. I told in the last slide, the gestational diabetes mellitus, your placenta making more hormones that cause rising of glucose in blood, and usually it will be handled by our pancreas. More insulin will be secreted, and that will be handled. And in some women, their pancreas may not be able to make more insulin to handle it. Those people will be having diabetes in the future, or they would be having gestational diabetes mellitus. Then HDL cholesterol less than 35 microgram per deciliter, plus triglycerides more than 250 microgram per deciliter, hypertension 140 or 90, or on therapy for hypertension, and A1C more than or equal to 5.7%, and history of cardiovascular disease. These are the risk factors. And then the main component, obesity, we'll discuss. We know the obesity can be typed into 2. Abdominal obesity, that is android obesity, and lower body obesity is gynoid obesity. Usually android obesity is seen in men, and gynoid obesity is seen in women. And another name is apple-shaped obesity, because this android obesity, the fat will be distributed over the upper abdomen, and the person will be having an apple shape. That is why it's named as apple-shaped obesity. And the other one is gynoid obesity. It's a pear-shaped obesity, where the adipose tissues will be located mainly over the lower abdomen and thighs and buttocks, etc. And central obesity. Other names are abdominal obesity, beer belly, pot belly, It's named as beer belly because long back it was considered, it was thought that due to intake of more alcohol, this kind of obesity happens. That is why it was named as beer belly. And pot belly, the abdomen is looking like a pot. And it consists of visceral fat or organ fat located inside the peritoneal cavity. We know our peritoneal cavity, and in that different organs are there. This kind of obesity, the adipose tissue will be located in between our organs, and our organs will be packed in these tissues. You know, medo vahanam srodasam vrika moolam vapa vahanam cha. The depots for central obesity is adipose capsule of the kidneys and omentum. In modern science, the depots for these of central obesity is adipose capsule of tissue and omentum. At that time, in our text, it was written long back that medo vahanam srodasam vritka moolam and vapa vahanam cha. We know during our degree times we used to correlate vapa vahanam to omentum and vritka, which is the kidney, and adipose capsule means it's a pad of fat covering the kidney. And how can we measure central obesity? It's through waist circumference. So how to measure waist? It's not simply like our the size of our trousers or something like that. The natural waist is defined as the narrowest part of the abdomen between the ribs and the iliac crust, as seen from the anterior aspect. You can see a white line, and that is the area where we should measure our waist. And that waist measurement depends on the ethnicity, because depending on our country or our area which we live, it changes. For us, it is in males, if the waist size is more than 90 centimeter, and in females, if it is more than 80 centimeter, it can be considered as central obesity. You can see in Japanese it's reverse. In male it is less, and in female it is more. That this is formulated taking into account the body structure of different races. This is a graph or a map put forward from that National Family Health Survey in 2014, I think, or 2011, and we can see the rate of obesity in all our states. Like Punjab, you can see the highest. I have marked it in red. In males it's 32, and in females it's 41. 32% and for males and 41% of female in Punjab from age 18 to 60 has overweight. And it's very least in Chhattisgarh. It is 10 and 11. And in Kerala, you can see it is 28 and 32. And in South Indian states, the rate is very high when compared to mainly North Indian region. So we'll go to the etiology part. Here, the genetic and environment interaction is there. When we think of environment, it's early life, and we can separate to early life and adult life. Early life means in low birth weight babies or the babies which were having poor nutrition. They have a tendency to develop obesity and other metabolic syndromes in the later stage. And adult life, thinking of adult life, there the main reasons are sedentary lifestyle and dietary factors. And of course, gene has a role in all these pathophysiologies. And then there was two hypotheses. One is the thrifty genotype hypothesis that was put forward in 1962 by James Neal. And in that hypothesis, he's narrating the evolution. The Homo sapiens evolved through the times of famine. Long back, our primates used to hunt for food. And then there will be a time after this hunt for some long time, there won't be any food, a time of famine. And then there will be another hunt after some days or some after some days, another 100 will be there. So we developed a thrifty gene to help us to store the excess calories which we eat when we have a nutritious, means food in abundance. And then that stored nutrition will be used when we have no food or when we are under famine. That kind of a gene was developed by Homo sapiens, and later many studies were conducted on this hypothesis, and a PTEN gene expression, low expression of PTEN gene was identified as thrifty gene, and low PTEN expression causes obesity and cancer. That gene was a tumor suppressing gene. Nowadays, the obesity is also correlated as a risk factor for cancer, and maybe this PTEN gene low expression can be a reason for that. And then this can be the low expression of PTEN gene or the thrifty gene is a reason for non-alcoholic fatty liver disease and polycystic ovarian syndrome, etc. This is a graph where we can see the calorie intake during the feast will be more, and there won't be any calorie intake during famine and up to another feast. Our body weight means nowadays calorie intake during the feast is there, but we are not having any famine. We all the time, every time we are having enough nutrition or more excess nutrition, and our poor gene which was developed earlier doesn't know anything, and it builds up our stores up the excess calories, and the body weight increases. And then the another hypothesis is thrifty phenotype hypothesis that was put forward by C.N. Hales and Barker in 1992. In that hypothesis, they are postulating that poor fetal and early postnatal nutrition imposes mechanisms of nutritional thrift upon the growing individual. The growth retarded newborn infants have reduced number of beta cells and reduced insulin secretion. That was a study conducted later. And in babies who were having poor fetal nutrition or early postnatal nutrition was very low, and in the adult stage, when they are exposed to the more nutritious diet or more lifestyle or sedentary life, they have the tendency to put on weight, and they have the tendency to develop diabetes and other related lifestyle disorders. The maternal malnutrition and the placental abnormalities will lead to fetal malnutrition, especially the amino acids, and thereby the beta cell mass, the islet function of the pancreas will be reduced, and the fetal growth also will be reduced due to infant malnutrition. And when they are becoming adult also, their beta cell function will be less, and that will lead to type 2 diabetes mellitus. This is another study, and in that, if fetal malnutrition is there, like other organs also have malnutrition, especially like liver, kidney, etc. If it's in the liver, that will lead to syndrome X or metabolic syndrome or non-alcoholic fatty liver conditions. And if it's in the kidney, due to the kidney problems, he'll later develop hypertension. And the other factors, the adult factors are the nutrition transition and the lifestyle transition. We depend now on refined food of animal origin, and increased fat for our diet, and lifestyle also has changed to sedentary lifestyle, and use of tobacco and alcohol is more. This point we can think of that Marshallese, the Marshall Island people, long back they used to hunt, they used to go for fishing, they used to agriculture was there at that time. They were not taking any refined food or something. Now this era, they are taking depending food for food from the US. Westernization or globalization, like different names we can call it, and epidemic of overnutrition is there. We had a very rich heritage, like the Kerala Sadhya. once it was told that there was 64 types of dishes for a traditional Kerala Sadhya. And it was Shadrasa Pradhana. It contained all the balanced diet. Means with delectable flavors and fragrant spices, Indian cuisine is certainly popular around the world. The wide variety of rich flavors, a traditional Indian diet also boasts of a wide variety of nutrients in a balanced quantity. If we check means our traditional foods, we can see it is very well balanced. Like dal chawal, it has a certain amount of carbohydrate, protein, and fat, like roti, sabzi, idli, sambar. Lots of study was conducted in US on the idli sambar. Regarding sambar itself, it's a well-balanced diet, and the Lancet journal has mentioned that Indians tend to consume more of carbohydrates, sugar, less of protein and plant protein than what is recommended for a sample adult population base. The next line you must think, despite having access to diversified dietary sources, we have diversified dietary sources, but we depend mainly on the refined food, then food of animal origin and increased fat. The main refined food we eat is the polished rice. The polished rice has high glycemic index and glycemic load, and there are many studies which shows the strong association of refined grain consumption and diabetes. And in South India, 50% of our total calorie which we take in a day depend on the polished rice. For example, when we take this idli or appam or putta or anything as breakfast, it's mainly made of rice. And for lunch, we take rice, and for dinner also, either we used to take rice or dosha, like appam, puttu, etc. That also contains rice. For 3 times we are taking rice as a staple diet. And the study shows that 250 grams of uncooked rice we are taking a day, and equivalent to that. And another study, white rice consumption and risk of type 2 diabetes, a meta-analysis and systemic review conducted at the Madras Diabetes Research Foundation, shows that polishing decreases the dietary fiber content and health beneficial nutrients of rice. When consumed as a staple food, it increases the insulin demand and elicit higher glycemic and insulinic responses, triggering the risk for type 2 diabetes and obesity. This is regarding white rice. White rice contains no nutrients, only that carbohydrate. So this is the state. And serum insulin levels are also reduced by substitution of brown rice. This Madras Diabetic Foundation conducted many studies. You can check for that in Google. Many studies are there available, conducted by this Mohan's Diabetic Center, and it shows the difference between taking brown rice and white rice for that. Then the next refined food we take is maida. All our bakery products, biscuits, bread, everything we have maida is made of maida. Maida has no bran, so no fibers, and it's also like same white rice, high glycemic index and glycemic load. It increases blood glucose levels to a peak within 2 hours. We know in preparing maida, in the production of maida, hydrogen peroxide and alloxan is used for treating wheat. And alloxan, we know when we do animal studies, we used to induce diabetes in animal using this alloxan. That is used for bleaching and softening of wheat to make maida. Then the third one is refined sugar. We use sucrose that contains equal fructose and glucose. 150 calories more a day. The rate of chance of increasing diabetes mellitus is 0.1%. And if that calorie is coming from a can of Pepsi, it is 1.1%. So it's 11 times more potent at causing diabetes mellitus than general calories. So it fuels the obesity epidemic. Then fast food, it contains high sodium. Acrylamide is there in this. If potatoes or tapiocas are fried in oil for a certain time, acrylamide and a chemical is produced, and that is considered as a carcinogen. And we know different flavors and taste makers we are using in our daily diet, like monosodium glutamate, etc. So that also favors. Then lifestyle transition. We have sedentary lifestyle. We are not having any all have majority of people have a white collar job. There is no physical activity, but our pets need physical activity, that we know. That is why we used to take our pets for their physical activity like this. And then a study conducted at Trivandrum, a comparative study conducted in Trivandrum among the government schools in Trivandrum and the Keralite Keralite students in Abu Dhabi, Indian schools in Abu Dhabi. And there, when studied their pattern, the 90% of the children showed mild to moderate level of stress. This was done in high school going children. And I was thinking when reading this article, because during my school days, I didn't know about stress. That was the our state, but now our children has changed, and 38.2 had depression and 48.9 had anxiety in this study. And now, after the etiology part, we will go for the pathophysiology. And it's not completely known. It has different cycles. So we'll go through that. The physical inactivity, the genetic factors, and our diet lead to central obesity. Central obesity I discussed in the previous slides, and that will lead to insulin resistance, and there will be hyperinsulinemia. The insulin will be more in the blood, and that will lead to dyslipidemia, hyperglycemia, hypertension, polycystic ovarian syndrome, non-alcoholic fatty liver disease, and non-alcoholic steatohepatitis, type 2 diabetes mellitus, cardiovascular diseases, cancer, chronic kidney disease, sleep apnea, etc. This is the picture of our first, that small one is the normal adipocyte or the normal adipose cell. When we gain weight, there will be hypertrophy of these cells, and along with the hypertrophy, hyperplasia, the number of these adipose cells also would increase. And the second picture, you can see the fat will be deposited in an adipocyte as lipid droplets. And finally, the cytoplasm will be filled with this lipid, and the nucleus will be on the side like a signet ring stage. This is a picture of a single adipocyte when in central we are obese. And these adipose tissues, along with these adipose cells, there is a blood circulation is there, which is carried out by capillaries, supplying to all these adipose cells. When they have hypertrophy and when they have hyperplasia, increase in number of the cells, the capillaries won't be able to nourish all these adipocytes. So that will lead to, and when we gain weight, that will gradually lead to a hypoxia, and there would be macrophage infiltration over these cells. And then from that point onwards, our adipose tissue will be function as an endocrine organ. They will produce many pro-inflammatory cytokines like tumor necrosis factor, interleukin 6, leptin, adiponectin, like so many chemicals would be produced by these adipocytes. And at the same time, free fatty acids will be produced. And the main organs taking part in the pathophysiology of this diabetes, type 2 diabetes mellitus with obesity or diabesity, is our adipose tissue, our liver, our skeletal muscle cells, and the pancreas. So this adipose tissue produces biologically active adipocytokines when they have this hypoxia, when macrophage infiltration is there following this weight gain. Like free fatty acids are produced, this TNF alpha, interleukin 6, C-reactive protein, leptin, so many adiponectin, so many are there. And there will be a free fatty acid flux to our blood. Our blood would be having more and more free fatty acids that will reach the liver, and liver also there would be when we have usually we know insulin is there, glucagon is there. When there is no glucose available in blood, this glucagon is there. There will be glucogenolysis, and glucose free fatty acids will be, means our fat cells will be used, glycogen will be used for our energy. And when we take food after a diet, when we have glucose in our blood, this glucagon activity will be suppressed, and in pancreas will be, the beta cells of pancreas will be producing insulin, and insulin will be mediating the uptake of glucose in our skeletal tissues and liver. And when the free fatty acid flux is there due to this adipose tissue, the insulin becomes inactive. That free fatty acid in our blood inhibits the insulin mediated glucose uptake in our cells, in our skeletal tissues and in our liver. Usually there is an insulin receptor in the cell wall, and insulin will activate that, and that will be activating the GLUT4 protein, and then glucose is taken by the skeletal tissue and is used for energy. And when free fatty acid and other chemicals are there, this is not done, and blood still contains more glucose, and the pancreas sends more and more glucose in blood, and depending on that, insulin is produced more and more, but insulin is ineffective, and then that stage we have hyperglycemia and hyperinsulinemia in our blood. Means there will be more glucose and there will be more insulin in our blood. That stage is the first stage of diabetes mellitus. That is called insulin resistant stage. Insulin is resistant to our skeletal tissues. Then what happens? Our cells having glycogen stores. So when glucose is not there for using for the energy, for their activity, they deplete the glycogen stores, and there also a byproduct is free fatty acid. In that process also, free fatty acid will be released to our bloodstream. So that is a cycle, vicious cycle, and that would end up in diabetes mellitus. So that is why in all these diabetic conditions, or on all these insulin resistant stages, we can't apply insulin. There, what we need is something for increasing that glucose uptake, or something to make that insulin sensitive. Our skeletal tissues and our liver should be insulin sensitive. For that, we can opt for exercises. We can opt for Ruksha therapy. All those can be done during that stage of diabetes. That is in the first stage. That is why that metformin is usually prescribed during the first stages by modern medicine. When there is a flux of this free fatty acid in liver, what the liver does is liver will produce more very low density lipid, and in turn the HDL will decrease and LDL in blood will increase, and that will lead to dyslipidemia and hyperinsulinemia. As I told, the blood contains more insulin, that will increase that would increase the sympathetic activity, that increases the sodium ion reabsorption in kidneys, thereby increasing the cardiac output. When sodium ion is reabsorbed in kidney, water also will be reabsorbed, like due to this osmosis, and increased cardiac output is there, and arteries also respond with vasoconstriction, and that will lead to hypertension. That is why we can see in people with obesity, diabetes, there will be dyslipidemia, and hypertension that will follow. That will later lead to this cardiovascular diseases and coronary artery disease, etc. So, insulin resistance and beta cell dysfunction as core defects of type 2 diabetes. So, insulin resistance is there, and later, in the later stages, beta cell dysfunction is there in type 2 diabetes mellitus. There is genetic susceptibility, obesity, and Western lifestyle are the causes I told earlier. And how beta cell dysfunction is happening. We know the over-secretion of insulin to compensate for insulin resistance happens when there is more and more glucose in our blood. I told, no, the pancreas secretes more and more insulin. There will be hyperinsulinemia, and hyperglycemia, chronic hyperglycemia also is there because the skeletal tissues and other adipose tissue or our liver are not able to use the glucose. So glucose also will be more in our blood, and there will be glucose toxicity. And lipotoxicity also is there because the high circulating fatty acid is there in the blood due to the that is coming from the adipose tissues, and when we don't have glucose for our skeletal tissues, they are using glycogen stores, and as a byproduct also free fatty acid is more in our blood. So this lipotoxicity, this glucotoxicity, and the hyperinsulinemia will slowly lead to beta cell dysfunction of our pancreas, and that will, at that stage, that is the later stage of diabetes. At that stage, insulin and other the medicines to stimulate the pancreas for secreting insulin are given, and the final stage, insulin is given. So hypertension, we know cardiac output is equal to heart rate into stroke volume. Stroke volume means in each beat the amount of blood that is pumped from heart. So heart rate is 70, and normally it is 4.9 liter. And the BP depends on cardiac output and the peripheral resistance. Peripheral resistance is the amount of resistance to blood flow in our vessels. So insulin resistance and hyperinsulinemia caused due to that causes increase in sympathetic activity, causing vasoconstriction, leading to increased peripheral resistance. How that is happening, I'll explain that. When we have sympathetic activity, the blood flow, means there will be peripheral resistance, and blood flow through our arteries will be reduced. So the kidneys also, the vessels of the kidneys also will be having less blood flow. That will result in the production of renin. You all might have heard about renin-angiotensin system, RAS. Renin-angiotensin-aldosterone system. That is the pathway for developing hypertension. So the decreased blood flow of the kidney will result in producing renin from kidney that will activate the angiotensinogen protein, that is inactive protein. That was an inactive protein seen in liver. This renin will activate that, and that will lead to the formation of angiotensin 1 and ACE. You all might have heard angiotensin converting enzyme from lungs is produced, and that converts this angiotensin 1 to angiotensin 2. And this angiotensin 2 stimulates the adrenal glands to produce aldosterone also. This angiotensin 2 is a vasoconstrictor, thereby the blood pressure is increased due to increased peripheral resistance. And at the same time, this angiotensin 2 stimulates adrenal glands to secrete aldosterone. Aldosterone makes the glomerular, means the kidneys, to reabsorb more sodium to blood, so that when the reabsorption of sodium is more, the water is also reabsorbed. Thereby, that will make the our blood volume high. Okay, when water is reabsorbed, our blood volume would be high, and this increases our cardiac output. So the angiotensin as a vasoconstrictor increases peripheral resistance, and aldosterone makes the increased cardiac output, making the high blood volume. These two causes hypertension. That is the pathophysiology of hypertension. That is why ACE inhibitor, if we can stop some reactions here, this cycle can be cut. That is why ACE inhibitor is a medicine given for this hypertension. That what that is doing is that is cut angiotensin converting enzyme is inhibited, and the angiotensin 1 to angiotensin 2 conversion won't take place. That is why that is how this ACE converter is acting. Medications for hypertension. Renin inhibitor. We can inhibit renin. We can inhibit renin. Then ACE inhibitor is there. Then angiotensin 2 receptor blocker is a medicine. Then diuretic. That by giving diuretic, that water reabsorption we can stop. That is the action of diuretic, and aldosterone antagonist. These are the medications used for BPs. We can think that our Punarnavadi Kashayam, like diuretic medicines, may be acting by this as a diuretic, this method. So associated conditions of this diabetes and obesity, or this type 2 diabetes mellitus, are hypertension, atherosclerosis, Alzheimer's disease, vascular dementia, obstructive sleep apnea, PCOD, microalbuminuria. So many conditions are there. I am not going into the details of all these. And the complications of diabetes mellitus, diabetes ketoacidosis, hypoglycemia, diabetic non-ketotic hypoosmolar coma can happen in acute as an acute complication, and chronic complications includes macrovascular complications. Sorry, the first is microvascular complications that includes retinopathy, nephropathy, neuropathy, diabetic foot, and dermopathy. And macrovascular complications, we have cerebrovascular accident, cardiovascular diseases, and peripheral vascular diseases. In all these complications, these chronic complications, after some 10 to 15 years of diabetes, or within this 10 years itself, we know the blood flowing through our arteries are altered. The character of blood is altered, and that causes all these problems. When in retinopathy, in nephropathy, neuropathy, everywhere, that our capillaries are affected, and retinal capillaries are affected in retinopathy. In nephropathy, in glomerular capsule, that capillaries are affected. In neuropathy, blood vessels or the capillaries supplying to our neurons are affected, and that is why neuropathy happens. And in diabetic foot also, it's due to the hampered blood supply. And dermopathy we can see in diabetic patients. In chronic diabetic patients, we can see over the skin dark spots. That's small capillary bleeds will be there, usually seen on the shin region in lower limbs. That is dermopathy. That is also considered as a microvascular chronic complication of diabetes. And the cerebrovascular accidents, cardiovascular diseases, and peripheral vascular diseases we know. And finally, diabetes can be considered as a disease of the artery, or disease of our blood. So moving to the Ayurvedic Samprati, Ahara, Vihara, and Manasika Bhava will be leading to Kapha Vriddhi, and Agni Vaigunya will be there, and thereby Ama Anna Rasa is produced. Thereby there will be obstruction of Medo Vaha Srodhas, and Medo Dhatu Agni Mandya will be there, Medo Dushti, and finally ending up it in Medo Roga. This can be correlated to this diabetes or a metabolic syndrome, and the Vada Vaigunya, which is caused due to the Srodho Dushti, or obstruction of Srodho Rodha, obstruction of Medo Vaha Srodhas. Hypertension also can happen. And the diabetes, the Samprati of Prameha, the Bija Dosha, Ahara, Vihara, and Vikara will lead to Kapha Vriddhi, and Bihu Drava Kapha will be there, and Meda, Mamsa, Kleda, Dushti is there, Vasti Prapti of Dosha and Dushya. then that will lead to the kapha prameha, then pitta prameha and vata prameha. It is clearly mentioned that this kapha prameha, pitta prameha and vata prameha are different stages of prameha. We know when we have the hyperglycemia and hyperinsulinemia in blood, in that obese stage, at that can be considered as the kapha prameha stage, and later when the other microvascular complications start to appear, it can be considered as pitta prameha, and finally when we have this neuropathy and in the final stages we can consider it as vata prameha. And when considering the samprati in Ayurveda, the Sandarpanota factors play the primary role. Kapha Medo axis is vitiated. Manda and Pichila gunas operate here, leading to Manthada of Dhatu Agni. And there will be functional Shrodha-Rodha. Due to this, Dhatu Sara won't be able to reach different Koshtangas and different Dhadus from Rakta or Rasa. And this becomes Asatmya to body and excreted as Kleda through Mutra. And the Samprati can be summarized as Agni Mandya is a main fact, then Mala Sanjaya is there, and Shrodha-Rodha. And we know our Dhatu Parinama, the Sara Bhuda and Mala Bhuda Dhadus will be produced. And when Dhatu Agni Mandya is there, the Sara Bhuda will be minimum and Mala Bhuda will be maximum. That obstructs the Shrodha-Mukha and it will lead to the Mala Sanjaya in Shrodhas. And this is this slide was prepared by my guide and the professor of Panchakarma. When I did my PG in Panchakarma at Kottakkal Ayurveda College, my guide was Dr. A.K. Manoj Kumar sir, and he used to teach us Shrodha-Rodha by this simple diagram. See, this can be considered as a Shrodhas, a cavity where free flow inwards and outwards is there. And when there is no Mala Sanjaya, this is clear. And when Mala Sanjaya happens, all these openings are obstructed, like Shrodha-Rodha, we can consider it as Shrodha-Rodha, and there will be Mala Sanjaya in Shrodhas. We know in insulin resistant state, insulin is not able to, means that when insulin resistance is there, insulin is not sensitized by the insulin receptor. That can be considered as an example for Shrodha-Rodha. And different presentations depends on the where the Shrodhas resides. So if the Shrodhas with Mamsa or Medo Shrodhas is affected, then that can be considered as leading to diabetes mellitus, obesity, raised low density lipid and raised triglycerides. And if that is located in heart, it can be considered as cardiovascular diseases. And if it's in the blood vessels, it's hypertension. And the Lakshana of diabesity we can correlate to Stula Prameha, and the features of Medoroga, Medastu Sarvabhudana Udare Hivevasthitam, Udare Vriddhi Prayo Medasvino Bhaved Bhava Prakasha. The features of Stula also we know. So thinking of management, Ayurveda, how we can opt for an Ayurvedic management? As a supportive therapy or as a combined therapy, or to minimize its complications. We are sure that the textual treatments or the textual references or the Ayurvedic therapies are not just hypoglycemic. So line of approach, our line of approach should be Kapha Medohara in the first phase of management, and then later the last phase, when the Vata predominant state, we can go for Vilya. And our targets is always to improve the functional status of Agni. Here, Agni Mandya is there in Dhatu level also. And to improve the functional status of Agni, optimization of Rasa utility. The Rasa must be utilized properly among the other, for nourishing other Dhatu, and remove the Kleda Sanjaya, and to remove Shrodha-Rodha. These are the targets. And this is the, when we aim the target, and the treatment is Shrodha-Shodhana, and the result should be like this. The management options are Shodhana is there, Shamana is there, Rasayana is there, Patyapatya is there, and Vyayama is there. Why and when Shodhana? When should we think of Shodhana? When Kleda, Meda, and Kapha dominance is there, and when the patient is Balavan and having only few complications, because these kind of patients with obesity, diabetes, BP, etc., always they have a risk of developing some coronary artery disease, of cardiovascular disease. So when we think of Shodhana, we should think twice. So we should do treadmill tests or all those things for investigations, necessary investigations in the patient. Then only we should go for this Shodhana like Vamana, etc. So dosha status must be Prabhuda. So the options are Vamana, Virechana, and Lekhaniya Vasti. And at Arya Vaidishala, we mainly do Vastis. Actually, in Prameha, Vasti is contraindicated, but Madhutailika Vasti is indicated in Prameha. And we go for Kshara Vasti, Vaitarana Vasti, Varanadi Kashaya Vasti, Varanadi Kashaya Vasti, and many formulations of Vasti are there at Arya Vaidishala, which is based on this Madhutailika format. Instead of Erandamula Kvada, the Kashaya will be changed. Like in Varanadi Kashaya Vasti, the Varanadi Kashaya will be used. And like in Madhutaili Amurda Mehari Vasti is a special Vasti done by us. And there the Kashaya, instead of in Madhutailika Vasti, we know Erandamuladi Kashaya Yoga is there. Instead of that Kashaya, we'll be taking Amurda Mehari. Medicine available with Arya Vaidishala. It's our product, and we will be taking Eganayagam, Chittamrda, Manjal, Nellika Toda. All these are the 4 ingredients of this Amrita Mehari, and that is taken and made into a kashaya for Vasti. The ingredients are upon as per the Madhutailika Vasti format. And Bela Vaidyadi Vasti. This Vasti is usually used in neurological conditions, because when the patient is having neuropathy, here Bela Vaidyadi Kashaya is used instead of Erandamula Kashaya of Madhutailika Vasti. The Bela Vaidyadi Kashaya is there in market as Vaidyadi Kashaya. There, Bela is taken, and then the other quantity, the other half is the Amrita Mehari drugs, and the Kashaya is made, and this Vasti is formulated. Then Meha Nashini Vasti is there. That is also done in diabetes patients. Then the mode of action of Shodhana is Kleda Nirharana, Kapha Chedana, Dhatva Agni Deepana, and Srodho Shodhana. And Shamana Chikitsa will opt after Shodhana, or where Shodhana is not possible, we can think of Shamana management to prevent the consequences of severe apatarpana. It can be external and internal. And Bahi Parimarjana Chikitsa, consisting of the Ruksha Kapha Medohara Stairyagara treatment, we can opt. The common practice, Udvartana, Takradhara, Dhanyamladhara, Kshiradhara, Sneha, either single or in combination, is used in the later stages when there is neuropathy, etc. And Udvartana, we did a special kind of Udvartana, and we, in patients having abdominal obesity, Udvartana was done over the abdomen, the lower and upper abdomen and sides, with Eladi Churna and Eladi Taila. Eladi Churna is the Eladi Yoga is Kapha Medohara. So we selected the Eladi Churna and we mixed it with Eladi Taila and made it into a paste. And with that we did Udvartana, because the patients are maybe having hairs on their abdomen and chest, so that is a problem. So considering that, we used Eladi Churna by adding little Eladi Taila in that, and we did Udvartana over the abdomen and sides, and we did a small study in 10 cases. It was not a clinical trial or something. We just observed the before and after waist circumference, and the results were encouraging that 1.5 inches an average got reduced. 1 to 1.5 inches was lost in all these patients. That was done for 14 days. Along with this Udvartana, the diet was also controlled, that I must say. But that helps, that Udvartana helps in mobilizing the fat. So then Takradhara, Dhanyamaladhara, Kshiradhara, Sneha in later stages are done. And internal medicines, that depends, different Kalpana, depending on the different stages of Samprapti, we can use diet and can be rationally combined for better therapeutic efficacy. Shamana Yoga like Varanadi Kashayam, Gulgula Tiktakam Kashayam, Asanadi Ganam, Vyoshadi Gulgulu, Trifla Gulgulu, all these medicines can be used depending on the stage of the patient. And then if the patient is obese, we can administer this Lodrasvam Ayaskradi Shilajadu, that is Meda Kleda Shoshana. And role of Rasayana, we must say, Shilajadu has the property to fight insulin resistance. So Shilajadu, we do Bhavana with Yashti, Padola, Trifla Kashayam, and it is given 1 gram twice daily with any Vyadhihara Kashaya, depending on the patient's condition. And then Trifla also we used to administer Trifla. So many studies are there on Trifla. It is a secretagogue, means that stimulates beta cells to secrete insulin. So that can also be given in the second stages, not in the first stages. The first stages when the patient is fat and when there is hyperinsulinemia and hyperglycemia in blood, we can opt for Shilajadu, and in the later stages, Trifla we can give. And generally this Rasayana enhances Agni and keeps Shrodas intact with minimal malasanjaya. The role of Rasayana is the correction of Dhatu Agni, prevention of Dhatu related complications, checking the ill effects of Vyadhi Kshamata Nasya, prevents the formation of free radicals, which leads to complications in diabetes mellitus, and as a therapeutic solution. Then the role of Adravya Chikitsa. We know Vyayama is Kapha Medohara. It provides Dhatu Sthirada. It's good for insulin resistance. So many studies are there related to the effect of physical activity in managing diabetes. That in the first slides I showed that a randomized controlled study conducted by American Diabetic Association in Marshall Islands. There also they formulated a specific protocol, like it has the physical activity of 45 to 60 minutes, I think, and plant-based diet also were given. No medicines were administered in that study. So the Vyayama is always important, and it's good for insulin resistance. And another study I've seen, 7,000 steps was the 7,000 to 10,000 steps a day will help in regulating means this insulin resistance. So then yoga and dhyana maintains sharira and manasika harmony, and it's good for stress responses. So Vyayama, Dhatu Shidilada is the main pathological event here, and Vyayama is Sthairyakrit. It increases glucose utilization, reduces the bad cholesterol, and improves peripheral circulation. So coming to importance of Ahara. So guys, glycemic index and glycemic load we must take care of while prescribing food, diet. So glycemic index, the carbohydrate quality in a diet, how much will affect blood sugar. Some food we know, some fiber rich food, the glucose is absorbed slowly. In some, like for example, in that glucose powder or white bread, within 1 hour, the glucose level will shoot up. So the glycemic index of that bread or that white rice is more, because that shoots up the blood sugar. It has high quality carbohydrate, whereas the diet containing fibers, the glucose is slowly absorbed. In glycemic load is another factor, that overall effect of glycemic index and amount of carbohydrate in a food is considered, because with glycemic index alone we can't rate a food, because in a serving the amount of carbohydrate it has, that also is taken, it should be taken into account, because in glucose, in pure glucose, 100 grams is glucose only, and whereas in grapes or in this watermelon, the amount of glucose in 100 grams is very less. So that should be considered. That is why later the glycemic load also is taken into account. The carbohydrate content in a serving multiplied by glycemic index divided by 100 is a formula for calculating glycemic load. We can see high GI food, the graph is very shoots up, and in low GI it's slowly in that 2 hours duration. So we can take the case of apple and the watermelon as example. The glycemic index of apple is 40. It's low when compared to watermelon. But in a serving of 100 gram, there is 15 grams of carbohydrate in apple. But in watermelon, only 5 grams of carbohydrate is present in 100 grams. So when the glycemic load is calculated, the glycemic load of apple is 6 and watermelon is 3.6. So the watermelon is also okay when compared to apple, even though it has high glycemic index. This is a recent study published in this January 2021. A glycemic index compendium of non-Western food. All the food which we take, non-Western diet, all the non-Western diet glycemic index is recorded and published. When I checked this one, these fruits like papaya contain very low glycemic index, and orange. In guava it is 78, and chiku it's 73, and many other records I have seen guava is around 50 only, and then jackfruit 63, watermelon 37, pineapple 19, and apple it's 45. All these are considered as low glycemic index food. Means apple, the ones below 50, apple, pineapple, watermelon, papaya, etc. Then brown rice has only 57.6, and whereas white rice has 77, 79, like that much difference is there between brown rice and white rice. Then tapioca it is 83, when dosha it is 55, putta 62. All these breakfast also is mentioned in that study. And there we can see one thing. We know that putta is also made from rice, and appam, that is also made from pure rice. But appam contains little fat also, because we do apply oil there for preparing appam. Thereby, that reduces the glycemic index of that food. So that may be the reason in olden times we used to take little amount of ghee with our lunch and all. And banana, even if it is Nendravada or Robusta, even any kind of banana, the glycemic index is very high, between 80 and 90. And another study, the type 2 diabetes and glycemic response to grapes or grape products. In that study, grapes was administered to patients, and in grapes, the glycemic index and glycemic load were very low, and it contained mainly water, and many flavonoids are there. And according to this study, grape are good for diabetes. And this is another graph, another table of glycemic index and glycemic load. And so ahara, in our shastra, it is told that use of pathya ahara like yava, sattu, kulatha, mudga, etc. must be used. And there is guru and apatarpana. Guru and apatarpana must be the diet we should take. Guru means the one which is slowly digested, or the nutrients are slowly absorbed to blood when we take guru kind of food. And that can be correlated to glycemic index and glycemic load. And apatarpana, in a low nutritious food is called as apatarpana, right? So we took the example of watermelon. It contains only, in 100 gram of serving, only 5 grams of carbohydrate is there. So that is apatarpana. So the concept of glycemic index and glycemic load can very well correlate with this guru and apatarpana ahara. Then fiber-rich food, fresh fruits and vegetables should be included in the diet. Whole grain breads, cereals, and brown rice, bran products, and millet can be substituted with rice. Millets, I used to take millet for breakfast and lunch. In millets, that like kodo millet, foxtail millet, all these millets, when we cook it, then it's like when we cook rice, means instead of rice, if we take millet, it's so tasty, and I feel it's better, means because it contains more fibers, it contains more nutrients. Like we can, chama is there, ragi is there, so many kind of millets are there, and that can be very well substituted with the use of rice at least once a day. Then ways to reduce. In the previous study, there was one table, there was one diagram, ways to reduce glycemic index of carbohydrate rich staples. Like if we take rice, how can we reduce the glycemic index of that diet? Add fats such as olive oil, groundnut oil, butter to white bread. I told no, adding fat slow down the rate of absorption, and thereby the glycemic index is decreased. And add legumes and high fiber vegetables to highly polished grains to lower GI. That is what we must take, more and more vegetables, or our traditional diet, I explained earlier, contained more and more plant derivatives in that, and use coarse grains instead of refined flour for food preparations, because it may contain more fibers, and the glycemic index also would be low when compared to the refined flour. And incorporate condiments such as cinnamon, vinegar, ginger into meals, as they have shown to lower blood glucose levels. And include protein sources such as meat, fish, egg when consuming carbohydrates, as proteins lowers glycemic index, like the fat. Like adding fat, we can add proteins also. In our diet, in our normal traditional diet, we have all these proteins, fat, and carbohydrate in a balanced way. And choose part-boiled rice or basmati rice instead of processed white rice. These are the recommendations put forward in that study published in January 2021. So this is an obesity diet which we prescribe to our patients at our hospital, and here also the rice is substituted normally with chama rice or ragi, etc. And in diabetic diet also, for lunch we used to give 1 cup of rice or 2 whole wheat roti, and other times we substitute it with ragi, yava, chama, and fruits and vegetables, etc. So the problem lies in our lifestyle when we think of diabetes. So the solution is, we know, the lifestyle change. How can we change our lifestyle is the solution back to Ayurvedic way of living. So the last 1 hour, I was presenting diabetes and all aspects. And thank you for patient listening. Thank you.
Now, anybody has questions, then please ask.
So please show the diabetic diet chart, please.
Okay.
Okay, thank you, sir.
Okay.
Click on that chart also.
I have a question. What can be the good combination of medicines, our combination, the Ayurveda combinations, where we can reduce the obesity as well as we can keep the blood sugar also in control. So that can be kind of a supportive apart from what you have explained us about the diet and the lifestyle.
Okay. Um, that depends, madam. Doctor, that depends on the condition. When if the patient has developed complications, the medicines will be different. And if the patient is in the beginning stage of the disease, means he was detected with diabetes, and he might be given this metformin-like medicines in the beginning stage. At that time, we can go for Varanadi, Asanadi Gana Kashayam, Gulgula Tittan Kashayam, and we can advise this exercise, lifestyle changes, and diet also. Likewise, we can concentrate on reducing the obesity factor, and in that stages now the patient will be having an insulin resistant state, or hyperinsulinemia will be there in the blood. So what we must do is we must make the glucose in blood available for every skeletal tissue. That is, we must try to reduce their insulin resistance. For that, this exercise help, and Kapha Medohara like medicines help, like this Varanadi Gulvitam, Asanadi Ganagashayam, etc. That is the management in during that stage, and in the later stages, it changes. Like I told, no. Shilajadu can be given in the first stage, and later when he's a diabetic patient who is taking insulin or some insulin in pancreas stimulating medicines, at that time we can shift to Kadaga Gadiradi Kashayam, Amridamehari Churnam, or this Triphala Churnam. All those can be given. And in the final stage, when neuropathy and all those complications are well established, at that time we can go for Bela Vaidyavani Kashayam and other Vada Hara medicines, etc. There was one case admitted here who developed this peripheral neuropathy, because he was not aware that he was having diabetes. He was 42 years of age, doing business. He was experiencing some numbness in his lower limbs of 1 month duration. He used to apply some oil, and it was off. And he was living in Dubai, UAE. And one morning, he was not able to move his legs. That stage he was, and at that time only he checked his blood sugar. It was above 200. That case we managed with Vela Vairiyadi and admitted treatments. We did Namdakiri, all those things, and the condition didn't reverse. But when he got discharged, he was able to stand for 20 minutes with a walker. When he was admitted, he was not able to. He was bedridden. He was not able to stand even with support. So he was not able to stand. That's it. Am I clear?
Yes, sir. Thank you. Thank you, sir.
Sir, please show the list of yogas.
We didn't make a list of yogas that we can practice, but I was just telling that I am different types of yoga we can do. I didn't advise. I don't advise any specific yogasanas.
Yeah. Hello, sir. Actually, in the management of diabetes, generally in the initial phases, it is very easy to manage because the patient is also listening to you and following up properly. But because it's a long course of disease. So how do we assess, and how long do we have to keep giving the medicines? Because that is one question which everyone asks. Till when do I have the medicines? The lifestyle obviously he has to follow, till he or she lives. So, it becomes difficult beyond a year to kind of, only manage with Ayurvedic medicines. So how do you recommend that this can be handled?
No, madam. Actually, diabetes, even if we are going for modern medicine or whatever therapies we are going, we can't cure diabetes, right? Cure diabetes in the sense means that patient, that person cannot stop their physical activity or cannot go on with their previous kind of high fatty diet. Likewise, he can't live, no. He must do physical activity. He must live with diet restrictions. All those things should continue, because we can see if we take modern medicine also, we are controlling our blood sugar with first it will start with a kind of medicine, and later it will change, and later it will change, and finally surely that will end up in complications. That the duration of complications to appear, that depends on the control. In some it may be 10 years, or some it may be 15 or 20 years. That is the root of diabetes, right?
Correct.
So
But then the medicine, how do you manage?
with our treatment also, we can do that. We can't say we can cure diabetes, but the diabetes is reversible with medicines, with physical activity, with all those restrictions. But that must be continued on his lifetime.
Okay, sir. Thank you.
Okay.
Good evening, sir.
Hello.
Good evening.
Hello.
Hello. Yeah.
Good evening, sir. So thank you for an informative lecture. Sir, I would like to ask is, with your experience, and if you could share a few details about the interactions between the modern drugs and the Ayurvedic medicines, because generally when a diabetic patients, now during our practice also, patients come with having allopathic medicines for years together. And then we got to introduce the Ayurvedic part. So what is your experience regarding, some precautionary measures with some modern medications, which we should not, or rather we should give the Ayurvedic medicines? Some particular drugs that you would like to mention, sir? The interactions of the allopathy and the Ayurvedic medicines.
Okay, madam, actually, I didn't come across any studies regarding the drug interactions regarding Ayurveda and allopathic medicines. But what we usually do is we advise the patient to continue with their modern medicines and give a gap of half an hour or 1 hour, means with our medicines. That's all. We didn't find any drug interaction, but we can see when they start our medicines and the advised diet and exercises, etc., and the blood sugar slowly comes down, and they can reduce their modern medicine. That can be done, madam. Drug interactions we didn't came across, and I didn't find any studies also, and we also didn't conduct any studies regarding that. But as what you told is very important, doctor. We must do that studies, drug interaction studies.
Hello, sir.
Hello. Yeah.
Sir, I have one question. It was a very nice session. Sir, when Vatachi Pramehi Rugna, what we should give medicine and Rasayan Chikitsa, and how we should think about this, like Shaman Chikitsa, when to give and when we should start the Rasayan Chikitsa, because that diabetes will be lifelong, no, sir? When we should start the Rasayana Chikitsa?
Madam, I didn't get your first question. Can you please repeat, madam?
Actually, in Vataj Pramehi, Kurusha Pramehi, when suddenly they will lose the weight, in that patient, what we can do, the treatment?
What we observe is, ma'am, when we see a patient, we can find out if it's kapha prameha or vadika prameha, etc. So in vadika prameha, we will be going for this triphala, we'll be going for bela vaidyavani kashayam, and we will be giving other medicines. For vadahara medicines we will be administering. In that case, the patient may be having this neuropathy signs, numbness, all those things. We will be giving that medicines.
Sir, and diet also, we in that patient we can't give kapha me dohara, like yava we can give that patient.
Yeah, yava we can give, no problems. No, Because, yeah.
Okay, sir. Thank you, sir.
Welcome.
Good evening, sir.
Good evening.
Sir, could you please tell the treatment of dermopathy, sir?
Dermopathy, no, that's due to, that happens due to I told, no, the capillary bleed, the small capillary bleed on our lower extremities, mainly over the shin and all. There will be spots like, in that case, we can try for improving blood circulation, treatments for improving blood circulation. Like we can try some lepana, we can try this udvartana, we can try rakta moksha in some cases. That depends, madam. This eladi taila all is good for that. And for in the case of medicines, we can prescribe this Brihad Manjishtadi Kashayam likewise.
Thank you, sir.
In Krusha Pramehi, and if the underlying cause is stress, what should be the line of treatment?
In Krishya Pramehi. Hello.
Yes, in Krusha Pramehi.
Yeah, usually the 90%, I told, no, 90% of diabetes mellitus patients will be obese, but there are patients who are not, who cannot be considered as having this obesity. So there also their abdominal fat or adipose tissue has a role. That was what these studies are saying. In that case, that depends on the condition, madam. If they are having in the insulin resistance state, like during the first states, then we will go for this kapha medohara treatment only. And as before giving brahmana, we'll go for lankana, right? Likewise, we'll start with some kapha medohara treatments like udvartana, etc. Then we'll shift to this vadahara treatments.
Have you observed stress factor in such patients, and any specific
Stress factors
for stress?
Yeah. Stress factor. Not only in Krishna Pramehi, all the patients.
And
Stress
what is the specific treatment for that regarding Pramehi?
Regarding Pramehi, the Mahatiktam Kashayam you can administer, no? That will handle the stress factor also.
Hello.
Hello.
Yeah, sir, I would like to ask the condition of ketoacidosis. What is the best remedy? Because it becomes an emergency.
Yeah, that better that refer that patient to modern medicine. That is what I didn't come across a patient, an acute complication of ketoacidosis in diabetes. Better being that an acute complication, refer that patient to modern medicine. That would be better.
Good evening, sir.
Good evening.
Sir, diabetic patient in pregnancy ladies, sir. Management, please, sir. Pregnancy 7 months.
Okay, 7-month pregnant lady, management of, no, it's better. I told, no, in gestational diabetes, some hormones from placenta makes our blood glucose high. Usually what happens in normal ones means the pancreas will handle it. But those who have less active pancreas or those who have insulin resistance, it's difficult. So at that point, we must give some medicine to stimulate the pancreas. So trifladi, etc. can be given, but in the 7th month of pregnancy, better go for insulin. That is why modern medicine give insulin during this gestational diabetes.
Okay, thank you, sir.
Rather than administering our medicines, no.
Good evening, sir. Good evening, sir.
Good evening.
Sir, in some patients, the a fasting blood sugar level will be continuously around 200 level.
Okay.
That one should be considered as normal for that person, or like even after medication the level doesn't change.
Okay.
So should we consider it as normal for that particular person, or should we change the like medicine?
No. Fasting blood sugar 200 means that patient has diabetes only, no?
Yes, sir.
He
Yes,
consider?
diabetes, but even under his under proper diet and exercise, well exercise, he does well exercise and he follows the regime. But
No, he has when he usually when we have means when we are under fasting state, the blood glucose should be below 100, right? And when at that stage the fasting glucose level at 200 shows that his pancreas, the beta cells, there is some problem with insulin and glucagon secretion. So he must do investigations and he should find out what is the reason behind this. Then only we can manage.
Sir, I think they should.
What is his postprandial blood sugar?
sir, in case of RBS also the condition will be same, sir. Like,
okay, then he needs investigation and the condition should be found out, because many other types of diabetes also there, no? So that would be better. And then only we can treat.
okay, sir.
I think the patient should be investigated for a Somogi effect or Down phenomenon, sir.
Yeah, good evening, sir. Sir, please elaborate the Basti treatment in Pramehis, because as it is contraindicated, I mean, what are the conditions where you go for Basti treatment, and for how long, what symptoms are there when you opt for the Basti treatment?
Okay, usually, as you know, Anuvasana Basti is contraindicated, and only Madhutailika Basti, in the indication part, Prameha is mentioned. So, what we did was we formulated different, I told like different kinds of Madhutailika Basti, changing the Kashaya or Kalka. Okay. And when we have a patient with this neuropathy and all, we will add Vaidyavani medicine. Or when we need to change, means when there is no complications, or when his blood sugar is high, and at that time we will go for Amrita Mehari Vasti or Meha Nashini Vasti, etc. But we will stick on to the Madhutailika formulation, and Anuvasana Vasti we will avoid. And Vaidharana Vasti we can do in that first stages of obese kapha type of disease.
Thank you very much, sir, for your very informative lecture. There is one query, ki what treatment you suggest for diabetic retinopathy?
Diabetic retinopathy, because I haven't treated a case solely for retinopathy. So that you can consult some Shalakya people, madam. That would be.
Okay. Thank you, sir. Yeah.
Sir, good evening.
Good evening.
Sir, one type 1 diabetic can leave insulin if he go with Ayurvedic treatment.
It's difficult, sir, because it's an autoimmune condition and their beta cells are not producing insulin, means we must give insulin supplement, that's all. So it is difficult to treat type 1 diabetes without insulin.
Sir, it may be difficult. It is possible.
It's not possible.
Thank
Not
you,
possible, depending on my experience.
Hello, sir.
Yes.
Sir, you have not told about that Rasayan Chikitsa. Means how long we should give, means like 45 days, then how much gap we should give in between that Rasayan Chikitsa. If we start Shilajatu or Trifala or Nisha Amalaki like that,
Yeah.
So
We can go for 45 days treatment, then we can stop, then we can continue other medicines.
so how long we should stop, sir, in between?
How long?
45 days we should give, and then in between how many days we should stop that rasa and chikitsa?
When we do triphala, when we give triphala, we used to continue, means not for 45 days. We continue up to means 6 months, 3 months, like that. We used to give, madam.
Okay, sir.
It's not like
Sir,
it's not like that classical rasayana treatment we are giving. No, we are giving Shilajadu 1 gram twice daily, or we are giving Triphala Churnam 5 gram twice daily. So it can be continued.
for means continue for lifetime, or we have to check in between?
No,
If the
that
patient-
depends, madam. We can't leave the patient after giving this rasayana. You take, it depends on according to his condition, according to his symptoms. We may need to change it.
Okay, sir.
Okay.
And sir, one girl, 8 years old, her weight is 48 kg, and
Okay.
her recently she's diagnosed serum insulin was 33.7, and symptom, yes, her symptom was she gained so much of weight, and that necanthosis nigricans
Nigricans was
was
there.
there, and Weberine was there.
Okay.
So I have started this. I gave her diet and Nishamalaki Rasana Kal morning time,
Okay.
and Triphala Musta and Guduchi. This
Yeah.
Kashaya for 1 month I gave her.
Okay.
So
Then what
1
was
month
the
I
result?
gave. Pardon, sir?
No, what was the result, madam, after 1 month?
No, sir. Still, she reduced 1 kg in 15 days.
Okay.
Weight. Because I told her to do exercise and all, but we have not checked the blood sugar level, because this still 1 month is not completed.
Okay. Madam, I think you can go for this Varanadi, like, or Asanadi Gana or Shilajadu.
Okay, sir.
Yeah.
She is 8 years old girl. Sir.
8 years old. But her insulin level, see, it is 33, right? Fasting insulin.
Yes.
Okay.
Serum fasting insulin is 33.7.
Oh, okay.
Hmm.
How much is her weight? 60 something, right?
No, 42.
42. Okay.
8 years old she's.
Okay.
So we have to continue this. I will continue for 1 month, then I will check for her again.
Yeah. Then you can think of Varanadi, Kanchanara Gugulu, Gugul Tiktam, Shilajadu, all those, madam. Asanadi Ganakashayam. Okay.
Hello? Pardon, sir. What happened, sir? What you told? I missed that. Some internet issues.
Okay. No, I was telling that you can think of Kanchanara Gugulu, this Varanadi Kashayam, Gulgula Tiktagam, or Shilajadu, I told. Asanadi Ganakashayam is good option. Triphala Gugulu, likewise, no? No, what you did is good, but keep this also in mind. Okay.
Hi, sir.
Hello. Yeah.
Sir, you advised Vasti Chikitsa. I mean, only Asthavana Chikitsa should be done, or Anuvasana should be done in between?
Actually, sir, Anuvasana is contraindicated, but we can do as Matra Vasti, 90 ml, 100 ml. Likewise, we can do if needed. Otherwise, for Madhu Tailika, we can go for continuous 7 days Madhu Tailika without Anuvasana.
Without Anuvasana, Vata Kotoba will be there, sir?
No, in Madhu Tailika, we can do like that, sir. No problems. Other Asthavana Vasti, this in between, we should go for Anuvasana. Matra Vasti, we can do, no? It depends, sir, on the patient.
Dhanvantaram is suitable in Pramehi?
Dhanvantaram? Which one? Dhanvantaram Kashayam?
Dhanvantaram Taila
is mentioned in Pramehi.
Dhanvantaram Taila suitable in Pramehi, sir? I mean, for Matra Vasti.
Oh, yeah, you can give, no problems.
Sir, one more thing. What is the experience of patients with this diabetic neuropathy, sir? Whether they are improving or they are no result, Like
no,
that?
no, sir. They are improving. I told no last. I narrated on case. No, a 42-year-old male was admitted with bilateral overlaps, and he improved a lot. Yeah.
Okay. I mean, for a daily usage, any drugs are there like the Ashtanga Kashaya, like that, Ashtavarga Kashaya, like that, useful, sir?
Yeah, Ashtavarga Kashaya is useful. Vaidyavani is useful. Vaidyavani is useful. It contains Bela and it contains Amrita Mehari medicine also. So that is very, very useful for that. And
some cases they don't respond, sir. I mean, in those, what should be the approach? I mean, it is irreversible in some cases. Does it is irreversible in some cases?
Yeah, some, sir, everywhere, some cases now that won't respond, right? So we can try Udvartana. We can, the peripheral circulation or the peripheral nervous system, means should be stimulated. For that, we can go for Udvartana, or we can do Abhyanga if the case condition is like that, with Prabhanchana Vimardhanam Thailam, etc. Vada Mardhanam Thailam or Vada Mardhanam Kodamba. Like
any Dhara Chikitsa, sir, Dashumala Kshira Dhara, like that in neuropathy conditions?
Yeah, it can be done, sir. It can be done. And one treatment we did was Dhanyamlana. We asked the patient to keep their both foot means up to the shin or up to foreleg. We keep in Dhanyamla. We'll ask them to keep in Dhanyamla for half an hour or 1 hour. And that also, that responds, sir.
Okay, sir.
Or Dhanyamla Dhara also you can try.
Sir, any experience in peripheral vascular diseases?
Yeah, peripheral vascular diseases we can treat, sir. No problems. That Vardhamana Pipali Rasayana, etc. are there, no?
Okay.
Yeah.
Thank you, sir.
Sir, what is the exact role of Shilajit in diabetes?
Shilajit, actually, Shilajit, when given as Rasayana, it in this insulin resistance, it helps. It helps in reducing the insulin resistance.
Sir, in diabetic complications,
Diabetic complications, sir, please.
Sir, is it beneficial in diabetic complications to reduce complications?
Which complications, sir? Neuropathy?
Yes, sir. Neuropathy.
No, sir.
Or even body pain.
Yeah, as a Rasayana, Shilajadu can be given, but in diabetes, we usually administer Shilajadu when it's in the kapha condition, means kapha predominant condition.
Sir, is it hypoglycemic?
Shilajadu is hypoglycemic. I don't know, sir. I haven't come across any studies like it is hypoglycemic. I don't know.
Hello, sir. Hello.
Yes, doctor.
Sir, just I want to use where to use Ayaskriti.
Ayaskriti, yeah, Ayaskriti also in obese patients, madam. In obese patients, when that the kaphaja stage, no, you can go for Ayaskriti.
And sir, Vataj Prame with glaucoma, how we can treat?
Pardon?
Vataj Prameha, old person by age of 78.
Okay.
And he is suffering from glaucoma also.
Glaucoma. Okay.
Yeah.
No, you can. Yes, madam.
So and Balakshaya is also there.
Balakshaya. Okay. There we can go for Vadahara therapies now, like Ashtargam Kashayam. This if neuropathy is there, Vaidyavani. Like Dhanundra Krida can be administered.
Okay, sir. Thank you, sir.
Good evening, sir.
Good evening.
Some patients are complaints of diabetic plus PCOS and diabetic plus hypothyroidism patients, sir.
Okay, that related, sir. PCOS and diabetes are related.
Yes, sir.
Some statistics is that 56% of patients with PCOS may develop diabetes. Something like studies are there. Yeah.
Sir, and diabetes and creatine level high, sir.
Pardon?
Creatine level.
Yeah, creatine level becomes high when that affects the means when nephropathy starts. Creatine level is means when it turns to chronic kidney disease, then creatine level is also altered. Yeah.
Sir, management, please, sir. In this case, sir.
If when the creatine level is high and what all symptoms he was having? So we can go for this Veeradaradi like Kashayams. Veeradaradi is there, Punarnavadi is there, Chandraprabha is there. That can be given, no? We can bring down the elevated creatine.
Okay, thank you, sir.
Okay.
Hello, sir.
Hello.
Hello, sir. Sir, the black spots that is called as acanthosis.
Acanthosis nigricans.
Yeah.
But not black spots, madam, black patches of skin.
Yes.
Yeah.
Yes. Sir, I got the result in one patient by leech therapy.
Leech therapy. Okay.
Yeah.
Okay.
Yeah.
Oh.
I got the results.
Okay. Where did you use that? Means leeching on the neck?
Yeah, neck, on hand, on chest.
Okay.
Yeah. The leech therapy gives results, but with all medications and diet and with all that things, exercise and all, and leech therapy gives results, sir.
That is due to circulating hyperinsulinemia, more insulin in blood, madam. That
Yes.
Anyway, good.
Yes.
Yeah.
Yes.
I'll keep
Sir,
them.
sir, your this lecture is very good. I really appreciate. Thank you for that.
Thank you, doctor.
Yeah.
Good evening, sir.
Good evening.
Hello.
Good
evening, sir.
I can hear, sir. Tell.
Sir. One of my questions, sir. Sir, I'm in Nanded, Maharashtra.
Okay.
Hello. Sir. For the obesity, sir, any drug to like Medari drugs in other companies, like in Kotakal, sir, in that?
You mean that patent proprietary medicine?
For the obesity. Proprietary medicine, yeah. Any classical medicine, sir?
Classical medicine we have lots, sir. Proprietary medicines we don't have. We have Varanadi is there. Varanadi Kashayam is there.
Kashayam.
Yeah, that Ayaskriti is there. Lodrasavam is there. Gulgulatiktam is there.
Okay, sir.
Yeah, Kanchanara Gulgul.
And sir, another question is, sir, any patients have to start the insulin injection, sir? But in that option, sir, some doses are less for in insulins in given the Kotakal medicines.
Pardon, sir? For insulin?
Injection is started to the patients.
Okay.
But patients are irritated. So that the doses are. Hello.
Hello. Yeah.
Can I speak in Hindi, sir?
Sir, I can understand Hindi, but speaking Hindi will be tricky. So
I will be try, sir. One of the patients, sir, have to insulin injection started. Patients.
Okay.
But that patient are very irritated for the injections.
Okay. So we need to some substitute.
Substitute for medicine, sir.
For insulin. कुछ नहीं है सर. इंसुलिन सब्स्टिट्यूट करने के लिए मेडिसिन नहीं है.
नहीं है क्या? समझो डोज कम करने के लिए भी कुछ है क्या?
है sir. With our medicines, what we can do is we can start our medicines and we can observe the patient, and when his blood sugar comes down, we can slowly reduce the dose of insulin. That we can do, sir. Very well we can do.
Which medicine, sir?
We can go give Kadaka Kadiradi Kashayam. I told Triphala Churna. So many studies have been done, like showing the property of secretagogue, because it stimulates the pancreas to secrete insulin. So Triphala Churnam you can give. Many medicines are there, sir. Amrita Mehari also you can give.
Okay, sir. And sir, one of the out of diabetes patients, sir, one of the cases, sir, my relatives are cancers for stomach cancers.
Okay.
They can give a treatment for the in Kottakkal, sir.
Yeah, sure, sir. We have a special OPD for cancers here.
He is calling in Kottakkal, but there is no response any for patients. So I have to ask, sir.
No, sir. Daily from from Maharashtra, from Latur, etc. So many patients are visiting our OPD, and the medicines are for a month when you come, and the medicines are free also. You can contact again.
Okay,
Hello,
okay,
sir. Hello, sir.
Okay, thank you, sir.
Hello, sir.
Hello. Yeah, madam.
Sir, I'm using Triphala Kashayam for diabetes and all retinopathy, vagera, all. So, sir, what I'm doing that I'm not using the simple Triphala. In that Triphala, I'm using a special hirida, that is Survari hirida. That I'm using, and it is giving very good results in diabetic retinopathy and all. So I'm using that. Changing only Haritaki changing I'm that making a special kashayam, and it gives very good results.
Okay, you are preparing the medicines, madam?
Yeah, one of my friend, he's having the Rasashala and all. He's giving me that Survari Haritaki, and fantastic results.
Great, madam.
Yeah.
Sir, management for the diabetic ketoacidosis.
Diabetic ketoacidosis.
Yes, sir.
Sir, it's better. It's an acute complication of diabetes, and it is better to refer the patient. I haven't come across a case of acute diabetic ketoacidosis, so I don't know regarding the management. But I think it's better to refer and take modern medicine. Yeah.
Hi, sir. In diabetic neuropathy, Sashtikshali Sweda useful or not?
Yeah, it's useful, sir. But that depends on the condition. When there is severe numbness and all those conditions, Shashtikishali is useful. We have done in cases, sir.
Thank you, sir.
Yeah.
So there is a request. Can you arrange lectures on thyroidism or hypertension and many more CKD like diseases, if possible?
Yeah, ma'am. That can be arranged. I think that you can contact our Mumbai branch, ma'am.
Okay. Thank you, sir. Yeah.
Okay, welcome.
Yes, sir, one question. I'm treating diabetic patients successfully, but sometimes I feel that, hello, can you hear me?
I can hear, madam.
Sometimes the sugar fluctuates. For example, in few patients, the fasting sugar is persistently high, whereas the PP sugar responds well. And sometimes it is vice versa. Fasting is right within normal range, and so the PP is usually on the higher side. So how do we alter the medication, or what can be done to normalize either of the increased sugar level?
Okay, sometimes fasting is increased, sometimes PPBS is increased, right?
Yeah, but that is in different patient. In one case, say patient X, the fasting is persistently high, whereas PP is normal. And in patient B, it is other way. Fasting is normal and PP is on the higher side. So in different cases, not in one patient.
Okay. And what is the age, madam, of the patient? That depends. And up to,
she is 50. One is 50, and other one is 58 something.
And since how long they were having this diabetes?
Long time, sir. Long time. So one is only on Ayurvedic medication, and one was under allopathy medication, and now her dose has been reduced. But she got COVID. So post-COVID, again, the sugar levels were quite high. It reached up to 400. So, but then after 3-4 months, but she's on allopathy as well. Okay, sir. So again, now it is fluctuating.
Yeah, actually, COVID, post-COVID complications means rise in sugar level is seen, because COVID has this cytokine storm. No, the same is there when that adipose tissue hypoxia and all those happens. The same high cytokines are produced, and our body will be in a pro-inflammatory stage in this case, and that after COVID also. See, so at that stage, that is the same stage like what I explained when that pro-inflammatory cytokines are secreted. No,
Right.
that is the stage, because COVID and diabetes there is relation, because the COVID virus spike protein attaches to this some particular cells. No, so it has some relation. So I think better you can try in after this post-COVID rise, you can try this Varanadi, Kanchanara, Google, etc.
Okay, okay. But it should be used in both patients who have fasting high and the other patient who is having PP high. So
no, this post-COVID rise, usually we can manage with this, I think. In the other cases, you can go with Trifla anyway, you can give, because this much duration they are having, no? Trifla can be given, and along with that, some if the patient is obese, you can go for this Chandra Prabha like medicines.
Hello.
Thank you so much, sir.
Yeah, welcome.
Hello.
Hello. Yeah, sir.
I have one patient with diabetic foot.
Okay.
But I am giving many medicines, but there is no perfect result. Please suggest effective treatment for diabetic foot.
Sir, does that patient has some ulcer, diabetic ulcer or something?
No, sir. No, sir.
Then what symptoms he's having?
Because his sugar also in normal limit. And patient is not the weight be limit. Weight is in limit. But there is 3 months while treating him. Some results, I have got some results. I'm giving him Vasan Kusmakara, Kandakara Sayana, and other Kashayam, Bhavanadi Kashayam, Ayashkruti, also giving it.
Sir, you can try some other treatments. Since he's not having any ulcer or something, you can give some Abhyanga, peripheral massages to stimulate the peripheral.
Using also Vrana Shodhana Telam, Vrana Shodhana Ropan Telam.
No, so Vrana is there, sir.
Vrana is clear. There is no infection. I think there is no infection at this time.
Okay, but ulcer is there, right?
No, ulcer, some wound, like wound is not oozing, it's a dry wound.
Okay. You can give Rakta Moksha, no? Rakta Moksha can be done.
Yes.
And then you can try Jatyadi Krida. Medicines are there, no?
Okay.
Yeah.
Sir, our Rasasunduram capsules and Ingula Bhasma also works very good in these stages.
Yeah, true, madam. Yeah. Rasa medicines also can be given. Rasa Sindura works. It works like an antibiotic.
Rasasunduram?
Yeah.
Sir, Rasasunduram?
Hingula Bhasma.
Hingula Bhasma. Yeah. Okay. Thank you, sir.
Yeah.
Hello, sir.
Hello.
Sir, my question is that my mother is diagnosed with hyperglycemia 2 months ago with PPBS 258 and fasting was 132. But then I have given her some Ayurvedic medicines. Now her sugar is fasting was 121 and PPBS was 165.
Okay.
But now she complains of indigestion. Sometimes loose motion, sometimes constipation is there, sometimes mucus mixed stool, and she used to go 2 to 3 times a day to toilet, but it's not clear. It's like IBS. So what can I do to improve her digestion?
Madam, is that due to some medicines which we are giving?
No.
Sure,
it was
right?
a chronic condition. Yes, from earlier also, actually her food timing was not good. She was walking. She was a walking lady. She used to come at 4 p.m. evening. Then she used to had her lunch, and from that time only she had this bowel problems. But now she's complaining of general weakness, and mucus mixed stool is there. So what can I do to improve her digestion? Can I use Chitrakadi Gutika and all?
Which one, madam?
Chitrakadi Gutika?
Chitrakadi Gutika. Yeah, you can, ma'am. And I think Mahatiktakam Kashayam is good. Indugandham is good. In IBS, we used to give Mahatiktakam, Indugandham, Drakshadi. This Kala Shakadi is there. Kala Shakadi Kashayam, you know? All these pieces.
It's a Kotakal based medicine.
Yeah, Kotakal. It's there.
Okay, can you please repeat, sir?
Yeah, Kala Shakadi Kashayam.
Kala Shak Adi Kashayanam.
Kashayam, yeah, that works well, madam. And Mahatiktakam is also good.
Mahatiktakam Kashayam.
Mahatiktakam Kashayam, yeah.
What would be the dose for that?
Dose like you'll be getting in 200 ml bottle. So 15 ml to be mixed with 45 ml warm water twice daily, morning and in the evening. And Mahatiktakam tablet also is there. The tablet.
Mahatiktakam tablet.
Yeah, it's available. Mahatiktakam Padam tablet.
Okay, before food or after food?
Before food. Half an hour before food, yeah.
Okay, sir. Thank you. And in Indukantam?
Indukantam is also good, madam, in these kind of conditions. Indukantam tablet is there, 2 tablets twice daily before food. If you are giving tablet, otherwise Kashayam is also there.
Okay, all are Kotakal based medicines. Right?
Yeah.
Okay, so thank you so much.
Okay, ma'am.
Hello, sir.
Hello.
Sir, I have a patient whose FBS is on the normal side, but PPBS is always on above 200. He is already taking allopathic medicine. Still, he is not under control. Even after prescribing Ayurvedic medicines like Madhu Mardana Churna, then also the diabetes, the post-prandial is not under control or not even reduced below 200. And his HbA1c was around 10.2.
7.2.
10.2.
10.2. Okay.
So what other medications can be given?
Ma'am, since how long he was having diabetes?
He is diabetic since 4 to 5 years ago.
Is he obese?
No, he is normal built.
Okay. Which medicine
The appetite is good.
Which modern medicine he is taking?
He is taking metformin, vildagliptin plus the triosert, vildagliptin and limiprid. All the 3 medicines he is taking.
Okay, madam, you please give him this Shilajadu, 1 gram with some Kashayam. Means Kashayam, you can go for this Varanadi or this Asanadi Gana Kashayam you can have. Or you can opt for Khadaga Kadiradi. Nisha Kadagadi is there. Anyway,
so what will be the dosage of the Kashayam then?
Kashayam I told, no, 15 means 200 ml bottle it's available. So 15 ml you can add 45 ml 3 times warm water and can be given before breakfast and before dinner. Okay, and this Shilajadu, Shodhita Shilajadu 1 gram along with this Kashayam. And
what Katakadi Kashayam and what other Kashayam, Asanadi Gana Kashayam?
It's there. Then Varanadi can be given. Nisha Kadagadi is there. Nisha Kadagadi is there. Hello.
Sir, thank you, sir.
Okay.
I think it is time to end the session.
Yeah, sir.
Hello, sir.
Hello.
Hello, sir. There was one more patient who was known diabetic and had the BPH earlier and underwent enucleation.
Pardon?
So
Underwent, ma'am?
enucleation of
Okay,
prostate.
enucleation. Okay.
Yeah, prostate gland. Now he is unable to pass the urine after surgery.
Okay.
So he uses nail cat every day for the to remove the urine.
Okay.
So since 12 years he is using the nail cat. So the allopathic doctors already said due to the diabetic neuropathy, your bladder is not working right now. So you have to use the nail cat. So what else can be given in Ayurveda to improve the condition or to improve the bladder condition? Is there any treatment?
Okay. The bladder is not working, right? Means
Yeah, the bladder activity has reduced too much.
some neurological involvement is there, no?
Yes, sir.
Okay, okay. Sir, I think better to means consult our that would be fine, I think, because without seeing the patient, no?
Yes, sir.
Okay.
Sir, I couldn't hear you. Pardon.
No, ma'am. I think we consult Mumbai branch.
Okay.
Okay. Because without seeing the patient, if he's having neurological issues, you can give medicines likewise also. Means like Dhanvantaram Kashayam or Ashtavargam or some that kind of medicines you can just try, ma'am.
Okay.
Okay. Okay.
Sir, neuropathy क्या बोल रहे थे?
Sir, can we get the recording, sir?
Yeah, sure, sure, sir. You can contact the branch, Mumbai branch.
सर न्यूरोपैथी के लिए आपने कुछ मेडिसिन बोला था डायबिटिक न्यूरोपैथी.
हाँ, yeah, diabetes के लिए, right?
हाँ सर.
Yeah, it's Vaidyavani Kashayam, madam.
वैरियादि कषाय.
Yeah.
Okay, thank you.
Okay.
सर मेरी मॉम को 20 सालों से डायबिटीज है, उसके कारण अल्जाइमर हो गया है, तो आप मेडिसिन बता दीजिए अल्जाइमर के लिए.
Pardon?
अल्जाइमर हो गया है, डायबिटीज कॉम्प्लिकेशन.
Alzheimer's.
मेमोरी लॉस.
Ah, okay, I understood. Yeah, B salsa diabetes.
Yes. Yes, sir.
So you can give that line of approach must be Belia, no? So yes. You can give this Brahmi Drakshadi like kind of medicines to stimulate her nervous system. Suvarna Muktadi Gulika or
Mahakalyana Ghritam.
Yeah, Mahakalyana Ghritam. Those medicines can be used, I think.
So dose bata dijiye.
Which one, madam? Saraswatarishtam.
Yes, sir.
Which one? Saraswatarishtam 25 ml twice BD.
So कोई दो मेडिसिन?
Pardon? दो medicine.
कोई सर दो मेडिसिन दे कि चारों दे दे?
No, madam. I was just telling few medicines. You can give this Brahmi Drakshadi Kashayam.
Okay.
Okay. And then Suvarna Muktadi Gulliga. You can give along with that. That's just that.
Okay, thank you.
Okay. Okay.
So we come to the end of this section. Good evening to all the participants and doctors. It's my pleasure to deliver the vote of thanks on this occasion. I express my gratitude to Rajendran sir, Honorable JGM CA, for delivering an excellent introduction. I also express my gratitude to Dr. Mahesh for giving such a wonderful presentation on this topic. It was really enlightening one. At last, I would like to thank all the physicians present here and the participants for their keen listening and observation. Thank you all once again.
Thank you, Dr. Mahesh.
Thank you, Dr. Mahesh.
Thank you, sir. Thank you, sir.
Thank you. Yeah. phone